So as you come from a big box store where you're probably not really looking at the financial aspect of most of those claims to, a much different role as a business owner, how did you move into that role a little bit? Did you have partners? Did you take that on yourself? And then two, what was your strategy when you started seeing these? Did you hire a consultant? Did you join a group? How did you start to really analyze the problem and figure out how you can move forward?
Sure. So in the beginning, because it's a learning curve for everyone, while the goal is always to make sure that the patient is the center of everything, when we had our grand opening in the beginning, I told our community that one day, I'm going to ask you guys for your help. I've reopened this pharmacy for you guys. And there was some people in the audience that were like there for 50 years. Their parents, their grandparents, everyone has been going to this pharmacy for ages. Some people used to come here on a horse and carriage to this pharmacy way back to get their milk, newspapers, and things like that. And they were so excited that I reopened, but I informed them that there would be challenges along the way. I didn't know about some of these things like DIR fees. But I said that as long as you guys are supporting me and willing to adjust accordingly, I'm going to keep this place open. And I'm not going to sell to a big box pharmacy, but I'll need your support. And they have supported me day in and day out. Anytime that I've had a struggle, for example, if there's an insurance plan that says, hey, you can fill it twice at an independent pharmacy, afterwards, you have to get your refills at a 3-letter pharmacy or through the mail. And I tell the patients that, okay, this is what your insurance plan says. They're like, I don't care what they say. We made a promise to you and we're going to help you stay open. So what do you need me to do? And for those patients, literally, we'll charge them $1 more than the cost of the drug, but they're loyal to me and they're helping me fight this system of what's happening and how people are forced to use different pharmacies and such. And for those people, I'll do absolutely anything for. It just shows their loyalty and commitment to the promise that they made to us to support local and why I've been continuing to fight. It's definitely challenging in the beginning. As I mentioned, I utilize that green call button on Pioneer probably more than most places. And I kid you not, if you ask my account manager how many hours I used to talk to him a day, not minutes, hours, at least a few hours every single day, I would talk to him. And he never lost his patience with me because it's like a kid in kindergarten or elementary school trying to learn about not just the pharmacy system, but about pharmacy and independent pharmacy and how all of this works. And I could say that there was different coaches, even other owners, Marc from Eric's Pharmacy, Chi-Chi, the previous original owner of Skip Back Pharmacy, Rob Franco. There's a lot of people that are fighting for independent pharmacies to stay open. And we've become a huge tight-knit family where if we're facing an issue, all of us are kind of in it together and we're going to work around it together. So while I didn't have the formal education or training or even partners per se to help me get through the initial struggles, I would contact these guys and my friends and other pharmacy owners. And that's the beauty about it is when I started, I thought that independent pharmacy owners, if it's in the same town or nearby, maybe they weren't willing to share some of these best practices with you. But then I realized that if we're not supporting each other, DVS, Walgreens, the Rite Aids, they're going to knock all of us out unless we're fighting together because they have 10,000 stores each. We don't have that. We might, even the largest independent pharmacy owner that has multiple stores does not have hundreds of stores. So unless we band together and work together, even if it's the pharmacy 10 miles away, we're not going to make it. And that's where the whole independent pharmacy community came together and really was like, Mac, we see you're crazy and that you're willing to do new ideas and just keep fighting and bring this pharmacy back. We're going to help you out. And that's where they did. And honestly, for the new owners, Facebook, there's a Pioneer Facebook group. It's not owned or operated by Pioneer, but there's people on there that care about each other. And you can ask a question on there and someone's going to have a brilliant idea to help. Because even the Pioneer community itself, whenever there's an issue, it's everyone's working together to see how we can advance different features, different ideas. It wasn't until last year where I've seen Ben Jolly's name pop up all over the place on Facebook groups.
Oh yeah.
And someone's like, you should just reach out to him and see if he can help you with integrating DIR fees. I know Pioneer has a wonderful platform to allow us to do it, but for me to do it accurately and do it within an hour, it was no brainer just for me to be like, all right, Ben, can you just plug in everything I need to know? And since that point, we've probably saved thousands and thousands of dollars knowing that this drug has a good DIR or a good GER, or this drug has a terrible DIR fee, and then making a decision accordingly. Before we were just blindly doing things for the first couple of years. So
yeah,
it's very helpful to have that tight-knit group of friends and pharmacy owners and even other pharmacists that are willing to help you succeed.
You live in a world where, so some of your patients may come in and they're on a lot of drugs, and some of them are branded and some are generic. Do you work with local pharmacies to kind of help them move through that world a little easier?
Yeah. So what's the idea of, 90% of prescriptions filled are generic. So that leaves us only not able to manage 10% of a patient's profile. And by manage, I mean fill. We can actually still manage that patient's profile 100%.
Right.
But the actual filling of that brand, looking towards a future where brands are more mail order, they fit better in a mail order environment. The cost of those brands are going to continue to go up over time. So most retail pharmacies won't want to deal with those. Most already don't. You look on the independent boards, a lot of pharmacies are trying to figure out ways to, convince patients to fill X prescription here, come here for generics, all that stuff. I mean, we possibly have a better and easier convincing point to the patient. It's just like, hey, we don't take insurance.
You have an easier leg. Yeah, you have a better leg to stand on. I just don't do it. Yeah.
Especially already kind of created that world where patients are becoming used to, prescribers are used to sending prescriptions, one here because that's what the narrow contract of your insurance requires, and everything else can go here. So I don't think it's going to become an increasingly easier argument to make as more of the market splits. And so we still help patients with those prescriptions, to your question. If a patient has a brand name medication that's kind of pricey, we'll help them either find a manufacturer assistance program to help them qualify for that, get it directly from the manufacturer for free, or we'll help them apply coupons. Well, like I have a patient today who I'll be calling her current chain pharmacy to get coupons applied. And we charge a cost consultation fee. So as long as we're able to save them greater than our cost consultation fee, there's no charge unless we save you money, basically, is how we do that.
I want to kind of go back a little bit when you kind of slipped something in there that was really profound, where you're like, you're charging a consult,
that's where I was going
consult,
Yep.
And that they don't get charged if you don't save them money is kind of like you just entered into a value-based arrangement, but the value there is to the patient. When we look at a lot of value-based care, we're, for the most part, when they talk about value-based care being the new thing, that's really a value for the healthcare system, not necessarily for the patient. And you've kind of taken that like, hey, if I don't save you money, you don't pay. How have patients approached, what's your general reaction look like?
And do you have some self-funded employers you're working with to help those patients? I guess the only thing I'd add to that.
Yeah.
Yeah. So, no, we don't have any self-funded employers yet. That's kind of the next piece. Is how do we convince them? We've had some conversations, but it all comes back to the broker relationship, really. Mm-hmm. Just so entrenched with brokers and
really
whatnot,
isn't it?
So, yeah. So it's just hard to have that conversation. From a patient perspective, it's generally positive. If I can say, it's the agreement, if I'm not going to save you this money, then you don't have to pay a thing. So it's really like a no risk situation for them. That being said, we've had some, 90 is a big upfront cost. Can we pay it over time or whatever? I'm like, your copay would have been 127. I'm already saving you. You got
and now
med,
it's $25 because Ozempic has this big, huge coupon now. So, or something, right?
Yeah, they were going to pick up the $127 medication anyhow. So $90 still is a fairly high upfront cost for some patients.
Yeah, that's true. I wasn't going to take it.
But that's a very small percentage of the patients. But generally, since we do enter into an agreement where there's no cost unless we save them money, they generally are for it. I think it's just more, they've never encountered that type of experience in healthcare. And so they're a little bit skeptical. Especially whenever I'm saving somebody with a manufacturer assistance program. We do charge a cost consultation fee for that. And because we do the application for them, we do the follow-up with the physician.
Right. Yeah.
We manage that whole application. So we see it as, you're going to get it for free. If you do get it for free, our time is valuable. So there's $90 there. But I've had patients saying, free medication, I don't want that. Like, there's got to be a catch there.
There's
the
right.
FreeDAR.
It's like, are you selling my data or what are you doing?
Yeah. So once I tell them how it works, I'm like, well, to a drug company, it's just a tax write-off. They can say that you can write off the whole face value or the list price of that drug as a tax write-off. It was a charity that they did. So it's really not free. They just, instead of getting it on their top line, they get it on the bottom line of taxes. So, yeah.
And they usually are okay after that.
The interesting thing, and since it's generally a pharmacist audience that listens to this, is I've had some pushback among pharmacists saying, charging outpatients save money seems maybe a little bit, just something we should do. The response is like, one of the best things, or one of the biggest value propositions we have as pharmacists, is actually knowing cost of prescriptions. And so, yes, we know a lot about how drugs work.
Mm-hmm.
But when we start getting into specialty disease states, unless we're kind of a specialist pharmacist, we still generally know more than physicians. We know more than patients for sure. But, one of the big things that we know is how much, or should know, not all pharmacists know this, but is how much drug costs and how to help patients save money. So that's kind of the response I have. And the other big thing is, everybody else is making money, saving patients money. So like even GoodRx, they make money by saving patients money.
I would say they make a lot of money.
They make a lot of money.
Yes.
And other big thing that I've recently realized is looking at their quarterly earnings, they have a division called manufacturer. I don't know. Anyhow, they made $17 million from manufacturers last quarter.
Wow.
Displaying manufacturer coupons on their website. And as pharmacists, we have reps come in, they give us coupons. We use it to, a lot of times we just throw them in the trash, but GoodRx is getting paid to display those coupons. We're actually the ones running those coupons through, navigating through the different coupons. It's not wrong for us to want to get paid for that coupon and price navigation service. We're doing a lot more than just sticking it on our website and making patients navigate through it and understand how they work. And so I would challenge all pharmacists to think about how you might almost make a service line out of helping patients save money.
What should a community pharmacy and independent pharmacist who owns a store, what should they be doing? What should they be working on?
Well, I think the first thing is we need to make sure the reimbursement is fixed. And I know people have tried to do that. I know NCPA, NACDS, and all of the other things there as far as DIR reform, and I think we're making headway. And I think that's the first thing, to make sure that they're making sure they're getting the best they can when it comes to reimbursement. I think the independent pharmacy needs to make sure they pick the right PSAO that they feel comfortable with, that's going to negotiate with them. And I also think that an independent pharmacy needs to get involved back to community-based, where they could potentially make a difference, and to go back out again years like they did in the past, to go out and speak to the community about bringing them into their thing. And there's organizations out there like CPSEN and other ones where it comes to clinical outcomes and things like that. And they need to continue to do that. Companies like Change Healthcare that I still consult for, the clinical product, and there's several other companies out there that are doing that. And I think they need to look at that as far as what they could do. Just sitting there putting pills in a bottle and worried about DIR and worried about clawbacks and worried about getting cut out of network, I think they need to look at that. And I think they also need to spend as much time as they can, even though it's costly, with the patient. And again, it's still trying to balance all of those things.
But I'm going to kind of add on to what Jeff asked, and you've been kind of saying in the background, but that we've also heard from other pharmacists who've had a very successful and thriving store, and that's they've got to get out from behind the bench and, get these med students in and let them get their years of bench experience while you're growing the business. So I think that's the biggest thing. Like Eric Larson is the biggest coach on that, is that get out from behind the bench.
Yeah, it'll be interesting to see what people do. Even though I talked to one pharmacist this last week, they paid $1 million in DIR fees last year. $1 million. Had it not been, and another guy I talked to had a long-term pharmacy that would have lost money last year without COVID testing. So, kind of this last year, COVID testing and vaccines have kind of helped, but kind of help them get their books back in order and fix some of their bad debt and stuff. But the question now is, well, what are you going to do next year? What are you going to do next year to make it?
So I think that's a well point. I talk to a lot of the pharmacy chains. I talk to some independents, talk to independent pharmacy vendors all the time. And unfortunately, or fortunately, because of COVID, those numbers were fictitious. So they grew tremendously, to your point, Jeff, last year. Well, how are they going to keep that up, or how are they going to do that? And I think there's going to be a rude awakening. And, listen, we hope the pandemic goes away. I know we talked about the fourth vaccine. We talk about future like flu every once in a while, every year or two, getting a vaccine for that. But I think that's going to go away, or it's going to go to the sideline temporarily. And they need to figure out where else they're going to make additional money. And I think, to your point, Marsha, by them coming out of the counter, by them spending more time with the patient, working things out with local payers, and doing some stuff there. Christian, I'm not sure, Tadras from St. Louis is working on some things as well. NCPDP, where I'm still involved on the foundation board, we're looking at value-based care and how standards could help promote that.
Yep.
And I think that's where all of this is going, because it's not putting pills in a bottle anymore, because you won't survive doing that.
What drove you to go, look, I see a problem. I know they have those issues too. Let me approach them. And did you? And you probably got cut up a little bit just talking to them, I'd imagine, just because sometimes that relationship is really warm, sometimes it's not. But
yeah,
give us something on that.
So for me, first, I was having trouble personally as a pharmacy owner, understanding the aspects of the pharmacy, other than I'm passionate about it. I love patients. I love patient care. The other side of wholesaler, math of what is your cost of goods, those things were challenging for me, to understand. And I would sit with several wholesalers, and everyone will tell me why the other person is actually wrong. And I said, wow, I've been able to figure out a lot of things, but it looks like this is way beyond my comprehension. So what can I do that I have self-control, that I love, that I understand how to get paid? So that was one thing that I was searching for. But at the same time, the way I took care of patients, whether when I was at CVS or at the independent pharmacy, I always liked to loop their providers back in. Like when I found something, I would always send them a message and say, hey, by the way, did you know this patient is also seeing a psychiatrist and they're prescribing these things? So my way of communicating was building friendships. So a lot of the providers, and I always laugh at the pharmacy, I say, oops, guess what? Dr. So-and-so gave me their cell phone now, so we're in.
We're in.
Because they start saying, I provide value. And so a lot of these providers were like, hey, here's my cell phone. If you ever need to ask me about my patient, just message me, because I was finding things that were critical. Right. So I started bypassing those faxes to a cell phone.
Right.
And then as pharmacy was getting tough, again, my curiosity, I just asked them, especially those who own their own practices, do they feel how I feel, that they love medicine, but maybe running the medical practice is not what they thought it was going to be? So those gave us relationships to communicate. And as I figured they're as stressed as me, I was like, oh, they're as a hot mess as I am. So you know what? Titles mean nothing.
Right.
These are people. So when I started really understanding the human-to-human connection, no matter what title you hold, when you run your own business, it's hard, right? So if we can figure out a way to work together and help each other is what I was looking for. And so when I knew that was an opportunity, I took it and I said, okay, let's see how we can make our lives better.
Yeah, it's funny you're talking about that. And when we talked earlier this week, you said something that I thought was really important. And you're saying that pharmacists right now are focusing on the things they can't do, and your life is kind of focusing on the things that pharmacists can do. And that just kind of feeds into, you found a doctor who felt the same way you did. Cool, let's do something with it. And that doesn't involve DIR fees or poor purchasing or selling.
Right. Yeah.
It's things that you guys can control and things that make a difference in those patients' lives.
Yes, because as I was searching, that was the subset of healthcare providers that literally got paid not because of goods, but because of services. And the more I learned about their services, I learned about services that they should do, but they don't, or they can't because they don't have time. And when I looked at those services, I said, that's up my alley. I can do those things for you, And then I said, and I would love to do these things, but I also have to stay in business, right? Mm-hmm. So that's the part that I feel a lot of pharmacists and providers get stuck, is the friend zone. Now we're friends.
The friend zone.
I have their cell phone.
I love that.
How do we make this a business relationship? But I want to tell you that they are very much interested in making this a business relationship if you can show them how. So a lot of pharmacists don't know how to show them.
Right. So do you think COVID and the lack of visits has kind of increased or made someone have a better appetite, a provider having a better appetite for maybe they said no before, or maybe that there was a wall there before? Do you feel like that wall's kind of coming down a little bit?
Yes. There's a lot of pressure right now.
Okay.
Because of the telehealth models, right? The virtual care. So providers who were so used to office visits, nationally, there had been a decline. Right in March, there was a 70% decline in office visits. Now they're coming back up. So it's about 40 to 50%, that they're probably less. However, they don't know that you can solve that, right? So immediately what we did, as soon as we saw the visits down, our team of pharmacists, we had a meeting and say, guys, how do we help these folks? Because we need them to survive. So they cannot go under, right? So we're the ones who actually put a strategy and say, hey, pharmacist, when you see a patient that has no refill, don't just fax the provider. What can we do to make sure that patient sees the provider virtually so that provider can bill for a visit and we can help them? So again, we solved the problem. And so for pharmacists, go in. You have access to these lives. They're coming to you. They're either walking in your lobby. You can take some blood pressure for them and send it to their provider and say, hey, could you initiate a televisit and then give us a new script so everybody wins?
Right.
Otherwise, when you fax it to them and they fax it back, that provider doesn't win.
Right.
So what can we do that actually helps them as well?
Right. Well, and even beyond that, I came out of the dialysis world prior to this, and a lot of the things we were looking at was how do we get patients to the dialysis seat? Not because that's how we got paid, but because if they missed that dialysis visit, that one visit, the next day they're in the hospital, right? And that $500 or $600 dialysis visit turns into a $25,000 hospitalization. And there's a real concern about patients that put off their their regular routine provider visits that will end up in the hospital later, and it's just going to just snowball the cost.
Yes. So COVID really, to me, opened up the door for better collaboration, especially with the remote access or remote patient monitoring.
Okay.
So we called our providers and say, okay, the folks are at home, right? We've been talking about remote patient monitoring, but it was something we're going to implement fully in the future, right?
Yeah.
Because they're like, oh, we got to think about technology. We got to think about this. Well, guess what? This is the time. So we ramped up and sent devices to patients' home with our drivers for blood sugar, blood pressure, and scales for the heart failure patients.
Right.
And as they are monitoring, within 5 seconds, we have the data. And our pharmacy technicians are actually monitoring. And they're prioritizing patients that are not on their optimal and sending a message to the providers. And the providers are initiating a televisit because they already have data.
And then let me link this back to some financials. And you and the provider are getting paid to do that remote patient monitoring.
Absolutely.
As an incident to, I am not the expert here, Josh, help me with even the wording, but, or Amina, it's basically incident to billing, right? I'm assuming under like a collaborative practice agreement.
So it's under collaboration.
Right.
Yes.
Okay.
That means the doctor is allowed to delegate.
Right. Okay.
Any clinician that they feel comfortable to help them in co-managing a patient. They get to bill for it. They get to be the overall supervisor.
Right.
And out of that revenue, they can pay us. And they can keep some.
Do you think, do you think that some of the genesis is on the payer side of is it mostly them reaching out to you now and going, we need to tackle social determinants of health? That's a buzzword / hot word right now. What is that genesis from their point of view?
One is consolidation, interestingly enough.
Interesting.
The vertical integrations have disrupted the horizontal integrations because you can't do both. It's a geometric impossibility unless you're talking about, one payer, one government, one, type of care. Because you have to, if in a marketplace, you can't have complete vertical integration and complete horizontal integration. That's just one entity, right?
Mm-hmm.
And so a lot of those vertical integrations have disrupted the horizontal relationships where there's a lot of plans out there now saying, wait a second, my vendors are competitors. I don't have a relationship with pharmacies. I kind of like the idea of having relationship with pharmacies. And so it's kind of disrupted the marketplace. And I'm the type of person also where an Amazon entrant, call me a Greg Popovich fan, but I think a healthy level of fear is great, right? Like if you want to talk about optimal performance, you need a healthy level of fear. And a market entrance like that gets people to sit up straight. But at the end of the day, they're not the major threat in the marketplace, right? I mean, it's self-channeling in these vertical integrations. And so the space between those vertical integrations is where a lot of the action is right now. And then the other is because we're 10 years in now on patient-centered medical home value-based contracting on the medical side, is that, there's that chart, right, Jeff, in software you talk about where it's like the peak of this and then the trough of disillusionment. And they're getting out now to the trough of disillusionment with, I've tried everything. I've hired care managers. I've paid primary care a bunch of money. I've tried behavioral health vendors. I've tried this and that, and they can't get numbers to move all that much. And now they're saying, well, wait a second. Why can't I work with pharmacy to change my HEDIS numbers, medical side? And so because they've tried everything else, and now there's actually some options out there for pharmacy, they're saying, wait a second, I can think of pharmacy as a specialty provider network. It's not just something that happens on the other side of my PBM relationship. So I think those two dynamics, the vertical integrations, and then also that they've kind of come to the end of trying everything but pharmacy.
Okay.
And now they're saying, wait a second. And COVID is contributing that. That's the third wild card because we're changing consumer expectations, which goes back to the whole craft beer phenomenon, right? Where if you have one craft beer company in a neighborhood, they do okay. But if you have more than one, they actually all do better. The reason for that is they change consumer expectations. Because it's one thing to say, oh, I got a great craft beer down here and I get it every once a month. It's a whole other thing to say, craft beer is everywhere. I'm giving up on Bud Light, Miller Lite.
And it's a better product.
Josh is a huge fan of craft beer. So,
and the thing is, you want to talk about, markets and dependency and stickiness. How many people do you know that started doing craft beer that went back?
None.
Right?
Zero.
Right? Once you hit that tipping point, they don't go back.
Yeah, and I'd say, that was the problem. That was the thing of independent pharmacy. Once somebody had done, the people who are not using independent pharmacy really never have. And once they get it, they want it, which is why they had to move. You started off with $4 plans and, hey, we're going to give you coupons and all this stuff, the CVSs of the world. And so they had to revert to trying to force people into, well, we're not going to let you make the decision, child. We're going to let your employer make the decision. And and we're going to do it that way.
Yeah, and I learned this from my mother-in-law, who worked in banking for a long time. So we ended up purchasing some real estate back home so we could spend more time back home. And she said, "Well, why aren't you going with the local bank?" And I said, "Well, I mean, I want to be able to have something that's national that I can." She said, "Well, but we do that too." And what I learned about banking is there's this whole kind of cooperative and local banks. That marketplace is different from the pharmacy marketplace, right? Because you still have kind of local banks and co-ops, and then you have the big banks,
right,
that are kind of depositories, but they're not really depositories anymore, right? And when people go, wait, I can lose my local bank and get everything that I would get from a national, they choose local banks all the time. Local banks and co-ops tend to actually thrive, and they're sort of making a comeback. And I think that's what we're trying to bring to pharmacy, which is how do you be all over the place, but really you still have that local owner with those local relationships. And I learned that from my mother-in-law in the banking industry. What we don't have in the pharmacy space that's in the banking space is this very standardized level playing field that says, here's what product has to look like in the marketplace.
Right.
And that's the whole Supreme Court ERISA.
Yeah.
That's the fundamentals of it, right?
You have a level of convenience that's perceived, right? Like a local bank for most people is more convenient than a bigger bank because they've had to be innovative, right? My local bank, I can use 20,000 ATMs across the country. With Chase, they want to charge me for every other one, right? But at the same time, you also see that banking has this huge advantage where no one tells you what bank you can or can't use, right? And that's something that clearly doesn't exist in pharmacy.
And since since the theme is economics, thank you for that.
right. No, we're staying in the banking
this
industry.
is my vacation for the day.
Let's do this.
There's another economic phenomenon that economists absolutely despise, including myself, which is subsidization is a real market breaker. And that's why one of the other fascinating phenomenons that's going on out there, good, bad, or ugly, or negative, or positive, but it's out there, is the whole good RX and the whole discount card stuff, right? Keep in mind that 49% of all employees in the country right now, by latest statistics, have a high deductible health savings account. I haven't used my Blue Cross Blue Shield insurance for drugs in 12 years.
Wow.
Right? Mm-hmm. Right? So this whole sort of direct consumer cash pay, you know, we know what direct primary care looks like. What does direct pharmacy care look like? Because 90% of our fills are 20% of the cost. And so, you know, to Josh's point, when we start talking about channeling patients and various mechanisms and vertical integrations to try to channel patients, that's only as effective as you need a specialty product or something that's so expensive that gets past your high deductible plan. That's where the world's heading. Right? So that's also a big market disruptor. And I don't know exactly what the play is for local pharmacies in that space right now, but there's a whole lot of people on Wall Street that scares them to death.
Yeah, maybe there's a good market for an RX local coupon card that doesn't charge pharmacy anything.
Doesn't charge, yeah. That doesn't rake
Yeah,
them.
go into your local doctors and say, hey, look, this GoodRx thing's taking 20% of my money, right? This is a local card. It's local friendly, and it doesn't charge me anything.
Yeah, and if it's done right, actually, you know, for the CPSN plug, we're all about how do we develop services in this space. So how do we work with you also, Doc, on working with hypertension and diabetes, where 60 to 70% of the patients on these major disease states are on generics that nobody's using their insurance anyways, and if they are, it's more expensive. So those probably end up being the models of the future. It's going to be fights with lobbyists and regulation and deregulation that's going to decide the fate of that. But the fact of the matter is, where we're heading is that the vast majority, we're going to be in a space where 5 years from now, 2% of the fills are going to be 70, 75% of the cost. So there's a very necessary bifurcation of the marketplace that's going to happen. The question is, how do you position these independent pharmacies as that trend continues?
So we look at the timing. A lot of people are talking about 2 years from now, there won't be any brand in independent pharmacy, right? that a lot of brands coming off, a lot of the big brands are coming off patent, et cetera. Isn't it time that we get rid of rebates? Rebates make it really hard for pharmacies to rebate. In my opinion, rebates are a lot of things just as bad as DRR fees. They make it really hard for me to plan to, what did I make on this drug, really plan my business. We see some buying groups across the country getting rid of rebates and going to straight pricing. I think this was, rebates were created, in my opinion, to create fog with PBMs. Well, the PBMs know it now. There's no fog, right? They know it. The purpose of rebates has passed. So what do you guys feel about that? What are you doing toward that? Do you feel like rebates still have a place in us trying to save and revitalize independent pharmacy?
Yeah, Jeff, we used to have a rebate model in our warehouse, and we eliminated that this year. So we had generic rebates associated with our purchases. We've gone to a net model.
Nice, congratulations!
Eliminated those rebates in the last couple of months.
How's pharmacy responding to that?
The response has been really well. I mean, we have it's easier for the RX purchaser to identify the price up front, what they're really paying. So the response has been overwhelmingly positive. And we've seen kind of record levels of re-engagement with customers that maybe have gone dormant because they didn't like the rebate model. It's been very positive for us.
Was that hard to get done? Was that a big, we talk about how IPC did that, we were like,
how heavy a lift was that?
Did Marc come in and like, yeah, this makes sense, we got to do this? Or was it really hard to do?
It wasn't hard to do. What was hard was committing to the decision. So I think the execution of it wasn't terribly difficult. It was really, and with Marc's leadership coming in and saying, yeah, we absolutely need to do this.
So normal pharmacy, what % are they getting from you guys? So you have some brand, you have generics. What's your average guy getting % wise?
It's anywhere between 3 to 5% from us. I mean, a lot of them are still buying from other secondaries like or they're on a portal such as a Trygstad, where they get those products. I assume we're getting most of the secondary brand business because we're one of the few that offer brand at a discount. Most others don't. But the market is about 10. The average pharmacy in totality gets 10% of their spend away from their primary wholesaler through the secondary market, of which we get anywhere from 1 to 0 to 5% potentially.
Yeah, which is their allowed leakage, which hopefully we see models changing where that's not the case, right? Yeah. Now that shipment, do they pay for that shipment? So is that guy who gets it in Hawaii, that's more expensive? So there's like some incentive to order once a week rather than every day or something like that?
No, Jeff, if you meet our shipping and handling minimum, $200 in generics or $5,000 in brand, the order ships for free.
You have that instant feedback. So because you've done the research, you've figured out what those effective rates are. And so you're able to monitor that in real time. What about a pharmacy that is just waiting to see what happens? So if they're just filling and billing, and just going strictly off, what's coming back. What do you think the lag time is between a transactional report today and what those finances are actually going to look like? When do they see that difference?
Yeah, I've spoken, not so much here recently, but especially, last year and the year before, spoken to several pharmacies that ran into that issue that says, when we were operating, when we were running our reports and everything looks good until they just come up. A lot of them, again, they don't have the business side of it. They're just running the pharmacy the best they know how. They don't have the stuff programmed in, and they're waiting 3 and 4 or 6 months, and they're going, something's wrong. I mean, my reports say I'm making money. The reports say I'm making X amount of dollars per script, but it doesn't. Something's not happening. We're not, and our expenses are more. Something's wrong.
Yeah,
I mean, I've talked to several pharmacies that have seen that, and then they don't know because, again, they don't know what's happening at the time, of adjudication. When they run that script, they don't know what's happening. So it's all about having
as accurate of information as you can. I mean, our PSAO just put out something new on another plan. I mean, I've got it set up where I start in January. I know that the first couple of weeks in January, I'm looking over this stuff and I'm making sure I got it programmed for the year. But you also have to, I mean, I look at our PSAO, I look at it daily. And I just check the news. Sometimes you'll get an email about it. Sometimes they'll slide something in, but you always have to be watching because something may change. And you got to be reading and staying informed so that I know if I've got to make a change into Pioneer. So
does that happen throughout the year, or does that only happen like?
It shouldn't, but there's they were waiting to sign a contract. What this one I'm talking about now is Express Scripts. And they didn't have, they've been one of the plans up until now that has not had a effective rate. And they just came out this week, sent an email out, and now they've got an effective rate. They were waiting to sign a contract, and I guess the contract they signed, they're doing an effective rate. So we've got to get that programmed in. I want to study that and make sure I got it right and get the numbers put in. So again, right now we're flying a little bit blind until I get those numbers in. So.
Yeah. And so how are you informed again? Did you say you went to the website and found it, or do you get a phone call that says, hey, heads up?
For the most part, they'll send out emails and it'll be a brief, one-liner saying, take a look at this or whatever. And you may you got to be to look at that. But I like to go on the website, and I'll catch it a lot of times before the email comes out. And there's a news section that will list, major updates like that. And I noticed it, and I know it's something that we've got to address here in the next day or so. But again, I want to make sure that I understand exactly what it is. I'm actually waiting on a list of bins that it applies to and group numbers, because you just can't go in there and say, hey, it's just Express Scripts. You got to go in there and program it correctly. I mean, but before this, Express Scripts was one of those that they paid poorly, but without programming anything, you knew they paid poorly. I mean, whatever you saw was what was happening, and that's fine.
That may have been 5 cents, 10 cents, 20 cents.
Oh, it was they were horrible. But now, so here's the deal. Just to explain the effective rates. Now, Express Scripts can come in here, and with the effective rates, you're going, holy crap! I'm making $20 on the script now with Express Scripts. No, you're not. You're losing 50. I mean, if you don't have that number in there, if you don't have these formulas, and it's basically just a percentage, they're basically saying on each script, whatever the AWP for that script is, we're going to pay you, 85% or whatever the number is, and you put that into Pioneer, and it does all the calculations for you, and it tells you truly you're either losing or making money. So, but other than that, you're making decisions, and you're buying drugs, going, oh yeah, I'm making $20, I'm making $20, I'm making $50, I'm making $10, and then 6 months from now you're going, how am I going to stay in business? It's because you didn't program anything. You don't have anything. You're not making good business decisions.
When you look at like just basic like adjudication of a claim, you would expect it to be a very simple arithmetic problem that you see number A plus B minus C equals D, and it's much more like one of those like detective maps with a yarn that just kind of goes all over the pens on the map on the wall.
Yeah, I mean, but between the rebate cost of the drug and whether it be a DIR or effective rate, I mean, there's just a lot of things that have to be calculated in there. And like I said, Pioneer does a good job. It's all laid out there for us. It helps our technicians be able to make a good decision without calling somebody up. They can tell exactly what's happening. And generally between them and a pharmacist, we can make a good decision, quickly.
Yeah. And so anybody on the outside, basically what he's saying is that you have to go into the software and say, if they say they're giving you $20, they're actually giving you $2, right? Like you have to plug in a formula that says what they send back isn't really what's happening. So what would happen if you missed that email? Maybe that email goes to your junk folder, and now all of a sudden you're dispensing NDCs that are not preferred. They're not on their formulary. Every transaction you do for presumably 3 or 4 months until you go back and actually reconcile, you're losing quite a bit of money, right? Or I guess theoretically it could go the other way. You could play it just right and be like, oh, cool, there's an improvement.
Does it go that way?
No,
but it could. We're trying to make the decisions to force it the other way. Yeah. Because again, there a lot of times, I mean, it happens a lot. There are NDCs that you can change to that have they call it a spread. It has a higher AWP spread between the cost of the medication, after rebate, whatever the final cost of the medication is, and what the the average wholesale price is, which is it's a database that says what the AWP is. You've got to find medications like that to help bump up your averages a little bit,
so you can stay in business.
Yeah.
So it seems like there's kind of a few prongs here, a few things that you have to do. First off seems to be awareness. If you don't know what your DIR fees are, you're in trouble. The second thing is, it seems like mitigation. You need to take that information, put it into the system, make sure you're taking that DIR fee into account. And that could be a percentage, it could be a flat rate, it could be an effective rate for the item. Like, it could be a lot of different ways that you're taking those fees into account. But then it sounds like you can also do a bit of optimization. So there are opportunities there if you're, playing within the confines that are given to you. So can you give me maybe like share a success story? Do you have a specific item that you can kind of nail down and say, this is one that we've optimized and taken advantage of?
We do have metformin as example of one. They make a couple different types of metformin. There's an osmotic metformin, and is actually preferred by patients because it cuts back on the amount of side effects that patients experience. But we were able to, talk to patients, talk to doctors about that, and that has been one that we've been able to optimize and actually make some profit off that by just changing the NDC. So that would be an example of one that has definitely, not only has it saved, is it saved some money, but it's also been more advantageous to the patient as well. So that's one example of that.
If you enjoyed today's episode, please like, subscribe, and follow us wherever you get your podcast.
Give us a 5-star rating on Apple Podcasts to help us reach more pharmacy professionals like you.